coverage by trying to understand its journey right from its inception to the present day and what the future holds for it. Post-pandemic world is grappling with how to strengthen our health systems for future pandemics and to ensure that everyone gets quality healthcare. In such a scenario, this conversation is of utmost importance. In our panel discussion today, we have three panelists, and this discussion will be moderated by Swaleha Shekhani. Allow me to introduce our panelists. First off, we have Amar Jesani, who is an independent researcher and teacher in bioethics and public health. He is a visiting professor at Yenapur University, Mangalore, and at the Center for Biomedical Ethics and Culture, Karachi. He is a co-founder of the Forum for Medical Ethics Society and its journal, Indian Journal of Medical Ethics, where he also serves as an editor since 2012 and is a member of the International Ethics Review Board for MSF. He has co-authored and co-edited 9 books, the last one being in 2018, volume titled Equity and Access, Healthcare Studies in India from Oxford University Press, along with Purendra Prasad. Next, we have Prasanna Saligram, who is a public health researcher associated with networks such as Jan Swasthya Abhiyan Karnataka and Medico Friends Circle. His interests include political economy of health, globalization, trade and health systems governance, and private sector regulation. He, in the past, also has been a coordinator of the World Congress of Bioethics held in Bangalore in 2018, and also a project coordinator of People's Health Movement's Equitable Access to COVID Technologies, that is EACT campaign. I now invite the co-organizer of this event, Priya Sharma, to introduce our other panelists and moderator. Over to you, Priya.
Thanks, Roshni. Good evening, everyone. Our third panelist is Professor Ritu Priya, who is a medical graduate with a doctorate in community health and is currently professor at the Center of Social Medicine and Community Health, Jawaharlal Nehru University, New Delhi. Her work links epidemiology, popular culture, political economy, and health systems analysis for developing an understanding of health culture, as well as drawing upon it for a contextually situated health systems development policy. She has been an advisor with public health planning at National Health Systems Resource Center under the National Rural Health Mission, and has also been actively involved with the People's Health Movement in our country for over 3 decades. Welcome, Professor Ritu. Moderator of today's session is Swaleha Shekhani, who is an assistant professor at the Center for Biomedical Ethics and Culture, Sindh Institute of Medical Sciences, Karachi, Pakistan. She has a social sciences background with a master's in bioethics. So now I request Swaleha to take over. Thank you.
So thank you so much for.
Left में shop है ना provision का कहाँ पे?
Sorry. Okay, so we're just going to start off with the session without further ado. We have a lot to discuss today, and universal health coverage seems to be a very popular topic because we have a lot of people joining in. While all the panelists are from India, and I see that a lot of participants are also from India, it would be great if we could talk about other South Asian contexts as well, maybe for questions, etc. So I think there's a lot of talk on universal health coverage happening right now, even in Pakistan, for example, where I'm from, with the Sehat Sahulat program, which has its issues. But over to you, Dr. Amar Jesani, to take us through the past of universal health coverage.
Okay, good evening to everybody, and thanks for having me here. As you can see, what I'm supposed to speak is about the past. But as all people are the right people to talk about the past, so that is how I was fitted in. But when I started preparing for this session, I realized that this task was quite enormous, and it has a long history. What I'm going to do is I'm going to look at how the various ideas related to universal access emerge and how they took shape, and then try to answer a few questions I have got about 10, 15 minutes, so I can't go into details of history quite a lot. But history is very long. I mean, you can see that it's 175 years history, which started sometime in the mid 19th century, from where I can take off and say that, well, this is a very long history. The second is that when we talk about universal access, I'm not talking about the ex-socialist country or the current socialist country. I'm just putting a focus only on the market capitalist economy, that how in those kind of setting or contexts in last 175 years, this issue has emerged and tackled. So the in a market economy, the broad strip that I use, and I think it has been used by a lot, is that by a lot of people, is that market on its own, its own interests, or the capitalist system has its own interests, which is very limited as far as health is concerned. That is reproduction of the labor and labor power, the workers who come from, right? And they must reproduce, otherwise you don't have workforce. And you must have a good labor power. That means either manual or intellectual or whatever, skills, chemi-skilled and all. And then it is also issue of that what kind quality of labor power will be there. That determines the level of healthcare that is required. So there is what it says is that in the capitalist economy, there is an upper limit up to which market on its own will like to make people healthy. And that's how it is the struggle of the people who suffer because of the health that determines to what extent the state and the larger society will be forced to create a system which is universal access. And a universal access system means that you create a healthcare, or the health determinants provisions, which are such that it is available to everybody, irrespective of their capacity to pay. So what I'm going to do is ask 4 questions and then 1 slide on each. How social determinant emerge as the arena of health action in the universal access? When and how the health medical care access found a crucial role in the universal access movement? What were the various strategies employed for universal healthcare access? And the relevance of various critiques of medicine and healthcare for healthcare system for the universal access movement. So these are the 4 issues, and then a little bit about India, and then I finish. So this is about the non-health and medical determinants. So the mid-19th century, as I told you, that was the time when this issue comes up and says that primary determinants of health and well-being are social, economic, and not disease treatment and the healthcare. That is, medicine plays a very, very small role. The idea originates with Engels. You might have read Frederick Engels, The Condition of Working Class in England, 1845. But more importantly, Rudolf Virchow, who establishes the science of epidemiology, and who talks about the social medicine, and who says that the disease condition in the society, how people get disease and have health problems, is very much determined by the social and economic condition in which they live. And so he gave a slogan that medicine is social science, and the politics is medicine on the grand scale. That means that it is what is more important in order to improve people's health are the socio-economic condition in which people live and survive and improve their well-being. You will find that this thesis, which still remains valid, has produced quite a phenomenal improvement in the health of the people of the developed country. The state intervention and elimination of infectious diseases happen in those countries before the discovery of a very effective medical care. I mean, You can talk about the infectious diseases and all, and you'll find that we have something which was very effective comes only in 1940s. And before that, all the non-pharmaceutical intervention that we were carried out, they were highly based on water supply, nutrition, education, all those kind of stuff that we can talk here. And that's how it is very important to understand that we will have to give that also an equal priority or more priority when we talk about the universal access. When Ritu talked about it, and he said social medicine, and he talked about, what is the role of doctors? And there was a big debate, discussion there. And some of you may be interested in going through the history. The doctor's job should not be just to treat diseases, but they should also involve in social change. And that's how I think most of the health activist group who are, at least in India that I know of, would connect with this too, that the doctors cannot remain just clinicians. They have to connect at the larger social level in order to change the society, because determinants are very, very important. And to deepen it further, you say education, health, and all, but then there are determinants of determinants, right? So you say you want to eliminate poverty, but then you have to also talk about that what determines poverty, what brings about poverty. Same way, if education is not available to everybody, why education is not available? What kind of social system we have? So that is a very, very important. And same is in the health and healthcare. That what are the determinants of it? If it is controlled by corporates and private sector, if there are pharmaceutical industries which looming large over it, they may be determinants of the determinants. We have to look that part too. So what happens until Second World War in developed countries by having a non-medical intervention to improve the healthcare never happened in colony.
Recording in progress.
And so, please mute yourself. And so it remains very, 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 very relevant for the LMIC. And with neoliberalism and the increase in inequities in the high-income countries, these issues have already come up there too. Now come to the second question and the second part of it. That when Ritu was talking about it in mid-19th century, the medicine was not as good as we have today. The biomedical model has not fully evolved. Scientific medicine has not come up. But in the latter part of the 19th century, things change. And germ theory comes, which tries to counter the determinants theory. And but at the same time, there is a whole evolution of healthcare system. So earlier in mid-19th century, you cannot even think of the real healthcare system. The healthcare system at the national or country level emerges as in the latter part of the 19th century, as the doctors get recognition as a professional, nurses, which they emerge in the mid-19th century. Even doctors' recognition came in 1857, when General Medical Council Act was passed. Nursing gets legal recognition in 1920, but they become the common sight in the hospital by the end of 19th century. And that improves the hospital thing. The hospitals earlier were for poor people to go and die. Rich people will always, stay at home and get the medical care there. So these hospitals emerge as a site for care only in the latter part of the 19th century. There may be exceptions, but I'm talking about in general how it was happening. So now you have one idea that is very important, that you must look after the socio-economic determinant, nutrition, poverty, all those areas. On the other hand, you also have the other part of that. And as that comes up, you realize that there was a more advocacy coming to that. By the end of 19th century, Bismarck introduced social insurance. First time, Germany, they pushed Prussia. That's where they said that, well, we have to provide something. State has to intervene to provide healthcare services too, or medical care too. And this was based on what is called the understanding of market failure in the healthcare. Market failure is very very pervading phenomenon in the market economy. But in health, it is more peculiar simply because the consumer does not have a choice what to buy, but there is an intermediary who normally, does that job for them. They may try to democratize it, but still the disparity of information and skill and all is so high that consumers have to be dependent on on what the doctors and others say, because they are the providers. So that causes the there is no competition that way. And that way you can say that if there is a more healthcare available or medical care available in a community, the market does not automatically lower the cost of healthcare and make it available to everybody. You will find that costs remain same. On the contrary, with more doctors, you will find that more medicalization, more use of various testing and all, and the costs keep going up. So this is a very, very important area that was debated in the early part of the 20th century. And on the base of that, the whole idea came that there is a vicious circle of what is called poverty causing more ill health leading to the private consumption of healthcare, and that going to lead to again poverty. And that vicious circle was considered to be very, very important to intervene, in addition to the socio-economic intervention. So earlier, as you saw that in the developed countries, much of the intervention was to eradicate poverty, nutrition, and all. Along with that, there is another intervention that develops is to provide medical care in order to treat the people who are falling sick. That's where also the debate comes up about whether the healthcare or medical care is a merit good or the public good, right? And many people who are market oriented would say that the medical care is not public good, it is merit good. Let people pay and buy. And on the other hand, if you want to break the vicious circle, you will have to ensure that the people don't have to buy at the point of receiving it, but there may be different way of financing. And that is where the connection is with the universal access. Come to the third part. How in the developed countries, the universal access system developed. What is common to all experiences in the early part of 20th century, the first half of the 20th century, was that there was a need for state intervention to regulate, control, reform market mechanism. And that was initially based on social insurance, where the state provided specific healthcare insurance to the workers or whichever the families that they considered priority. In addition to that, in European society, you will find that instead of just allowing people to keep paying from their pocket and become impoverished, there were civil society organizations like trade unions, and trade unions affiliated what the civil society organization called a friendly society. And all of them created a kind of health system in the NGO sector, what we call voluntary sector, in order to take care of their members. So that the reach was very limited, but they did do this in a quite a big manner. Same thing. This was friendly society and trade unions intervention was more in England, but in other European countries, the private practitioners, when they found that they were not able to get the fees from the patient, they also encouraged at the county and village level formation of societies where some kind of risk sharing is done through some insurance mechanism. So all of them were developing, and when after Second World War they decide to have universal access system, most of them are nationalized. The UK's National Health Services developed by nationalizing friendly societies because they were voluntary sector. And if you read the history, that was what was taken over by the government in order to create secondary and tertiary care services there. So post-World War, when there was a big crisis within the developed countries, the working people have given their own youngsters to fight the World War and sacrifice themselves. So there was a big competitivity in the masses, and that led to UK. You all know about the Beveridge Committee report, which issued into the National Health Services. But the other Western European countries too, the same thing happened. In Canada, by mid 1950s, they established a hospital insurance, universal hospital insurance. And by 1971, the medical care, which was also made universal. So this whole approach was based on what is called communitarianism, that the country's citizens are our community. And in community, those who are having more wealth are supposed to subsidize those who are having less wealth. That means you have to create a very progressive taxation system in order to finance it. So those who are able-bodied, young people, working, having employment, they need to pay more. While those who are children and those who are old, they are taken care of by the by the society without any taxation payment. So it may be based on a special tax, or it may be general tax, which is used in order to finance this kind of universal access system, which came about. The NHS is the model where the secondary and tertiary care services are directly provided by the by the state, so the public health system. While the primary care, that is the general practice services, which is contracted in by contracting in the general practitioner. Almost 40% of the doctors of UK are general practitioners, and they are contracted in. And this communitarianism is very important, and the solidarity is very important to do that. The other European countries have done it by the combination of this as well as by contracting in hospitals and others, or by buying the services from the private players. They have certain strong rules in order to ensure that those who get engaged with the state do not have any kind of conflict of interest. So that means if your hospital is contract in, then you cannot provide any private services from there. So this is this is a kind of the system that has emerged, and I think their strategies have echoes in today's debate also. In USA, that is a different system, which is based on private providers, but still almost 45 to 50% of the healthcare expenditure is paid for by the state. And so those who are having jobs, stable job, they can, as a part of their employment contract, they get private insurance. On the other hand, those who are poor, those who are old, those who have served in the war and then they got injured and all, that is veteran services, or the Obamacare, which where certain other people who were not being covered, they are covered by the state welfare. And so there also you will find that there is a huge involvement of the state. So state intervention in financing and in certain cases in provision is the most important historical lessons that we learned, that without that it is not going to be possible to have universal access. This is my last part of this, that from late 60s onwards, when a lot of what you call identity movements comes up, the movement against racism, movement of the women against on the gender issues and all. So this started issue, evolving with the whole idea of inequities in the universal access system. So we can talk about that in the developed countries, they had established the system, but they still had a lot of inequalities within that. And that created a major crisis. So you'll find that women's movement, the feminist movement, came out with a very, very strong critique of the national health services and the universal access, saying that it is gender blind. The Black report in UK showed that there was a race issues involved, where the people from the blacks were not provided the adequate healthcare services, and they were also suffering more from the diseases because of the inequalities in society and all. So these are the critiques which are very, very important, that in the future, if you are going to set up any national health services, you just cannot have simple access, but you will have to look at the other part where the inequities are also tackled. The other aspects of the critique was medicine and its practice. That means, is it scientific medicine is the only way of providing services? You have a Sri Lankan experience where they use scientific medicine as well as indigenous medicine. And that means, can we talk about monopoly of only scientific medicine or the modern medicine in the universal access? Another thing that had come out, and some of you might have read Ivan Illich and all, is iatrogenesis that is created because of the irrational practices that is fostered in the scientific medicine. The corporate control and the distortion of science because of that. That is coming up in a big way with COVID crisis. We have seen that how the research was carried out. I won't go into detail of it, but the science is not independent from the corporate interests. Actually, much of the science is financed by the corporate interest. The science which is for application, while the basic science is still done and financed by the government, but it is all ultimately given out to them. And as a consequence, they are making more money and they are distorting the way new evidence that come up in the medicine. So the universal access system further comes under pressure in 1980s, and that is a demand for high-tech medicine. And the countries which established universal access, they were not able to fulfill it by making more investments. So that is that way it started having more and more market within the universal access system. That means people pay as a co-payment. So you get free services, but if you require certain kind of testing or certain kind of procedure, then you provide co-payment there. The solidarity erosion is also a big issue today, because you know that there is more rise of fascist and proto-fascist movement, which does not care for another section of the people within the civil society. And that also is another reason where there is no unity, and saying that, well, we should be solidarizing with the people who are less fortunate and do something that. And this universal access system has certain problems of bureaucracy and inefficiency. I think all of us know about it, so I won't go into detail of that. And this is the last one. This is on India, very little bit. And as you know that we started in 1947, where we had a report called Bohr Committee report, which gave a promise of inaugurating a welfareist universal project in healthcare. And the entire thing, when it was built around the primary health centers, where both medical care as well as public health functions will be carried out, and it will be supported by the secondary and tertiary care. But it didn't work. By the end of 1960s, it was very clear that government was not putting money where that was needed, and there were disillusionment. 1970s starts with the Kalmata approach that emerges with the lot of experiments done by the NGOs, the community health workers and all. They also combine primary health care as an intervention on determinants of health as well as on the access to healthcare. So these are I think, what you can, some historical developments there. You can have debates about what was 1970s in India. That was a transition phase when the government services were failing. Private sector had not become overwhelming as it is now. And that is a time when we go for the primary care issues, but there was no primary care itself. I mean, Alma Ata had an implicit model of universal access, but it was not articulated as an universal access access advocacy. The universal access advocacy comes in India only after 2000. Till then, the private sector proliferates, and which ultimately becomes so powerful that by the time we come up with that, we are too weak to control them. But that at least comes up in 2000 when the health movement starts raising the issue of private sector regulation. It also starts talking about the universal access to medical care and healthcare. So this is what I would call a backdrop or kind of a history on the approaches to the universal access that I have found. There are, I think, 2000 onward, but I am sure Prasanna and Ritu will be covering it, that what has happened in research past in the developing country, like say Thailand and Brazil and other places where they have tried to establish, even partly in South Africa, where they have tried to establish universal access systems. So I'll leave it here, and then as others talk, we can then have a discussion on that. Thank you very much.
Thank you so much, Dr. Jesani, for such an insightful presentation into the past of universal health coverage. Participants, if you have any questions, you can post it in the chat box. I will just ask Dr. Saligram to take us to the present of universal health coverage. And we have 15 minutes per talk. And so over to you, Dr. Saligram.
I'm neither doctor nor Saligram. I'm just Prasanna anyway. So we in MFC JSA have this rule that we drop our doctors and surnames anyway. Thanks, Amar. That was a good. Thanks, Amar. That was a good overview. I am always time challenged, as some of you might know. I cannot complete within the given time, so I'll be more didactic, which I generally don't like to do, but today I will be a little bit more didactic. Thanks, Amar. That was a good history to start off where you left for me to continue and then see how we go. Are all of you able to see my screen?
Yes, Prasanna, we can see it.
Cool. Okay, so Amar gave a nice overview of 150 years, but it's actually 400 years from what Amar told, the struggle in the UK for universal health and that sort of thing. I'm always confused in what to use as a title because we keep challenging the whole phrase of universal health coverage, which I will try and talk through now as to why we don't talk about universal health coverage, even though that's become the buzzword recently. So I'll just give you an overview of what I'm thinking. I thought there could be some beginners, and that's how I put in 1 or 2 slides about the politics of health. So that would be one. Then I will talk about definitional issues with universalism. Then what is universal and not universal, and the current understandings of universal system. What does it mean, and how the private sector that Amar talked about, what does it mean to engage with this? We call it the hot ghee phenomena in our local language. Neither can you spit it out, nor can you swallow it. So that's the private sector. And then regulation and universal health system. So quite a bit to cover. Let me see how fast I can do this. Generally, I start always with the politics of health. So this is a great statement, and neither is health there, nor planning commission there. Nothing is anymore there in this country. I have often referred to 11th 5-year plan as an education plan. He is referring to the national education policy, which we have enough critics about, critic to talk about, but we will lay special emphasis on health in the 12th plan. Of course, the 12th plan never saw the light of the day. So that's how that's where we start. Okay, so this is a classic NFHS data sheet. I'll just draw your attention to the last column. So infant mortality, under 5 mortality is almost 3 times for the child of a mother who is not literate. So less than 5 years of education. So that is what it shows as the social determinant. Then you have the same across the axis of wealth. The poorer the family, the higher the infant mortality rate, again 1:3, and of course the dominated caste and dominant caste differences. So what I'm trying to tell you is health is very socially mediated. And health is the more unequal a society, the more ill a society is, or unhealthy a society is. So when you have inequalities, equity and health go together. And where we talk about equity, you have to talk about politics. And Amar did mention about this. I just put this about in the cartoon. I became sick because of my poverty, and I became poor because of my sickness. So that's the mutually reinforcing loop. But becoming sick because of poverty is much more stronger than the other way. But that's also okay. So I will run through this. So what is politics? Politics is the search for a common good and a just society. That's the definition of Beauchamp. So what we are looking for is social justice. When we look for equity, so when we talk about rights and equity having very close connection with health, we need to talk about politics. So if we don't talk about politics, I might be preaching the choir here, but I'm just preparing the common ground as to why we are where we are. So Virchow's statement, Amar already expanded. Medicine is a social science and politics is nothing but medicine on a grand scale. And Navarro fantastically says social determinants of health are amenable to political actions. So this is just a quick overview of the relationship between politics and health. And then we come to principles of a universal system. What should it be? It should be one system, not a targeted, in which the services for the poor are poor, and elite go to 5-star services. So that is the fundamental principle. Amar talked about risk pooling and solidarity, in which it is one system, which is so that even Prasanna and the Ram Prasad is in the village person, going to the same system rather than 5-star services for Prasanna, mediocre services for the poor. And then the cross subsidy, I give an example of the Indian Railways. Still, I mean, it might not stay more than 6 months. The cross subsidy of moving a set of people to a particular destination by the rich subsidizing the poor, which Amar also talked about. And an important tool of universal system is what is called as utilization of monopsony power, so that the state steps in as a big volume purchaser and then thereby says, I am going to give you so many volumes, just like how you do bulk purchasing, and then you drive down both the costs and also improve quality. The classic example again, and what Amar gave, Canada dissuades high net worth individual, people with private insurance cannot be part of the universal system and vice versa. That means the providers who are part of the universal system, that is, who are using volumes, cannot also think of big profits. So it cannot be both. So that is the important concept of what is called as monopsony power. Then a universal system moves away from the dichotomy of public and private and moves towards a single system. It also holds the promise of moving on the path of health in terms of preventive, promotive than just curative. I would also add it would move on the path of also social determinants, not necessarily medical care. So I will throw 5 definitions or 6 phrases at you. Unfortunately, I cannot do a dialogue for want of time. So it is in the nature of the capitalist or capitalism-based health biomedicine that there is always a constant conflation between the phrases. So Amar briefly also explained the capitalist nature of the biomedicine, and which results in lots of conflation. For example, we started with primary health care, then it became primary care. Primary health care was much larger than the medical curative part of it. But then ultimately it was reduced to medical care, as in primary care with some immunizations, some mother and child health, and some primary, secondary disease conditions taken care of, not health in that sense. So there are these 6 phrases or formulations that are thrown around, and not all of them mean the same. So I'll try and explain. So universal health is the Right Royal Health for All declaration from Almata, which was based on social justice, human rights, and included social determinants of health, not just medical care. So this health for all was given by WHO. We have to bear this in mind. The Health for All declaration was given by WHO in a conference, Almata conference, okay, through primary healthcare, basically comprehensive primary healthcare. Then somewhere we moved to universal health care. So this is the care which would encompass preventive, promotive, rehabilitative, and to some extent traditional systems. So we are still in the medical, we are slipped from health to medical care now. I hope all of you are able to understand. The health as an overall well-being, health as a sort of be all end all concept, including social determinants, has been given the go by, and now we have only we are slipping into universal health care. So this is focus on health care, which includes preventive, promotive. So classic example is NHS, which Amar explained. And then we have access to universal health care. I'll just come back to this. And then we have coverage. So in the universal health care, there's a difference between coverage and care, and access. Coverage is more top down. I have done my karma, for example, that the health administration says I have provided one primary health center for 30,000 population. So there is coverage already done. But does that mean access? Not necessarily. So that is why MFC and other, we largely in the movement have been were talking about access to universal healthcare rather than just coverage. And then the mother of all, the coverage problem. The coverage part of it is financial coverage, largely to minimize out-of-pocket expenditure. So from a grand idea of health for all, we reduced it to health care and then further reduce it to health coverage. And this is not without politics. So as the politics evolved from post-World War, as Amar talked about, to neoliberal system of 2000s, we slipped from universal health to some coverage. The coverage meant that anybody can give the provide services as long as they are covered. It could be unwanted hysterectomy, unnecessary C-section deliveries, but as long as you are covered, as in the financial coverage, you are there. So the irrationality, the unnecessary procedures that one would think of is all given the go by as long as you're covered. So this coverage means financial insurance coverage rather than the experiential universal health that we all started with in 1940s. And now the pretense of health is also dropped. Now the formulation is universal health care coverage. So even the health is removed now, and we only have health care and its coverage. All of you are able to follow, I hope. So, and now what we are moving towards, beyond all these formulations and conflations and confusions and this thing, we want to move towards something called as universal health systems, which I will talk about. So the choice of definition of universalism is a highly political matter. Why would, for example, the next one is WHO definition. An organization which gave the fantastic concept of health for all as universal health, why would it want to slip to universal health coverage? And see the definition here, somebody affordable cost, and it should be financial risk protection. So ultimately a fantastic human nature of health being reduced to something which is just about risk protection, financial protection. Again, it is part of neoliberal dogma, which I don't have too much time to explain, wherein markets, even though market healths are market failures, how neoliberalism was brought in. Neoliberalism brought in this whole concept of coverage in which there is competition for the market rather than competition within the market. Sorry, it is beyond the scope for discussion here. And then, of course, high-level expert group, which had some of the MSc, PhD friends, tried to give it a different, tried to what to call, how do you say this? Tried to hijack the whole coverage debate into moving it towards access universal, and also talking about social determinants of health. But of course, the politics killed this high-level expert group recommendations itself. So that's the politics of definition. Okay, so what is not a human universal system? Mere provision of an insurance mechanism, that's not universal system. Not merely a package of services to be covered. It is not meant to be that you just have an insurance package to cover some healthcare conditions. When there is a total absence of associated regulatory mechanisms of the cost and quality, then also it is not considered a universal system. Then universal systems don't target. That's a fundamental difference. You don't target with APL, BPL, all of this. And who becomes BPL, who becomes APL, we all very well know. I mean, sorry, for the non-Indian ones, sorry, this is a little bit more Indo-Philic. Non-Indians, it is the economically weaker section. So you don't target the poor. This is a fantastic contribution of World Bank, which has resulted in segmentation of the services, that is elite services for the rich and poor services for the poor, because World Bank prescribed that why should rich be part of a system, breaking the solidarity that Amar explained when we talked about universal system. So targeting the poor means you are breaking the cross subsidy, you are breaking the solidarity, and you are breaking the risk pool, because the poor are sicker, the older are sicker, and so if you break the solidarity, you only have a bottomless pit in which the coverage keeps on covering the sicker and the poorer and the elder population. So, and of course, total absence of people's participation and lack of grievance redressal. So community participation, which Alma Ata espoused. Yeah, this is that famous cube, for want of completion, I'm putting it, which doesn't mean anything in the larger scheme of universal health. So this is just that how much can you cover, what are you covering, who are you covering, sort of a thing, which doesn't speak to actually universalism. Okay, so what is the current thinking as SAPC has given me the mandate? What is being passed on as the pathway or the route map to universal health system is what is called as publicly funded health insurance. It could be your Rashtriya Swasthya Bima Yojana, which was there was a precursor to that, Yashaswini, then there was Arogya Shri, then Rashtriya Swasthya Bima Yojana, and now you have the much touted Ayushman Bharat, which is given more money now in this budget. So you keep on pumping in money to a bottomless pit because the cross subsidy is lost and the solidarity is lost between the populations. So this is a fantastic case from Karnataka, and Arogya Shri, this cancer hospital was enrolled. What does it have? It doesn't even have a ICU, and it only has one ventilator for the whole hospital. And every time the government kept on reimbursing the hospital. And this is again a classic case. So MP moves away from a fee-for-service based system to a capitation system, and then all of them withdraw from the services. So the moment Janani Sahyogi Yojana was brought in Madhya Pradesh, there was a quantum jump of 60% cesarean section, because it was supplier induced demand, what is called as. Sorry, these are all some technical jargons. Supplier induced demand is when you have a pot of money available, the supplier then induces the demand, be it cesarean section or be it unwanted LASIK surgeries. And now the latest fashion is hemorrhoidectomy. So since some of you are also ethics people, I thought I will put some of these horror stories in front of you. So again, uterus scams, hysterectomy scams. You have UP hospitals misusing RSBY, treating men for gynecological diseases. So you have the whole spectrum of irrationality, unscrupulousness of the supplier-induced demand, because it had a specific orientation of fee for service. If I do normal delivery, it is 2,500 rupees. If I do C-section delivery, it will be 4,500 rupees. Naturally, my inclination is to do more and more C-sections. So that is the tragedy. And of course, you have had 2 children. Come on, come to the hospital. Why have uterus at all? Let us remove the uterus. So that is the tragedy of the hysterectomy, irrational, unethical hysterectomies in this country. And of course, there are articles which say how 20-year-olds are menopaused in this country. Sorry, I was reading a commentary of universal system from Pakistan, some article. Again, the conflation of universal system with the healthcare system. I think that's a major problem. There was an article, I forget the person's name, who said that we can now move to universal health system, universal health coverage system, as they were talking only about healthcare. Universal systems are not only about healthcare; they include health in its totality, social determinants. So again, coming back to this, NHRC issues notices to governments of Karnataka and Maharashtra or alleged hysterectomy. So this is what is the roadmap envisaged. Now it is on a grander scale. Earlier, these used to be around 100,000 rupees, 100,000 to 150,000 rupees per year. Now we have 500,000 rupees per family given, and that is all going channeled to private sector. So instilling fear, this is an article in the Indian Journal of Medical Ethics. Instilling fear makes good business sense. Unwarranted hysterectomies and then DC orders, and then fantastic, what is called as in economic parlance, supplier holdup. If you can see the top and the bottom, on Jan 16th, the doctors go up in arms, telling that they are going to stop treating patients with government insurance cover. And the next day, as you can see, Jan 17, 2017, government agrees to review the treatment costs of insurance schemes. That is, the doctors, because the public system is weak, and this current model of universal system as thought about universal coverage, so to say, thinks that private is there, private, the market romanticization, and then so the public system is systematically weakened, as a result of which the government has no power to negotiate or to drive down costs or to drive quality. So what happens? The private sector goes up in arms on January 16th. Jan 17th, already the government is agreeing to review the treatment costs. So doing this consecutively, Andhra Pradesh landed itself in huge trouble because it kept on revising the rates every year. Each time the doctors would go up in arms, the providers, and then the government would revise. At one point in time, it became a tipping point in which the secondary and the tertiary care became, the expenditure on tertiary care became higher than the expenditure on primary health care. And any public health article, textbook, anything you read, we keep on eulogizing that primary healthcare is the way to go, but invariably it is about private sector, it is about tertiary care, because that is where the money is to be made. And these are 2 classic cases of unethical practices in this country. Sorry, I'm giving India examples, but the rest of the countries are also not very different in some sense. So here is a classic case of overcharging of a patient, and imagine the profit margin. This is not by us, we are all maybe still activists. This is by a government authorized national pharmaceutical pricing company coming up with a study telling that this hospital charged 1,700% more. So is this the model that we have to have as going forward as universal system? That's not it. So what are the issues? So coverage of some care for BPL families, some access. We have titled it one of the articles. We have titled it as some access for some people for some of the times. Recent paper that came out in 23 now January, PHFI schemes have not meant anything for indigenous communities. They are more curative than preventive, only tertiary without secondary. And I talked about the Andhra Pradesh example of tertiary care expenditure exceeding the primary care expenditure. Of course, there is cream skimming. All the difficult cases are transferred to the public system, and the so-called raison d'etre, the justification that WHO gave when it when it brought out the what you call definition of coverage, universal health coverage, slipping from Almata was the reduction of out-of-pocket expenditure. But what we have seen is that people who have availed these schemes, so-called roadmap to universal system, have had no reduction in out-of-pocket expenditure. And in fact, the ones who have utilized PFHI schemes have had more out-of-pocket expenditure because there is no backward and forward linkages. They would have done already polyclinic, they would have shopped around before they could land up in a scheme, and would have incurred enough out-of-pocket expenditure. And of course, medicines are never covered by any of these schemes. So in that sense, that's not very surprising. And then supplier holdup, which I talked about, the private sector constantly demanding revision of fares, and fee-for-service orientation, which invariably makes it irrational and unethical. And of course, some of us have worked on how to regulate the private sector. So there are about 32 instruments. I won't go into this. I will share this PowerPoint later with Roshni and others for them to circulate it to the participants. So there are a host of things that a system has to undertake to regulate the private sector to move towards universal system. We have hardly anything. So out of 32, we could map only about 4 or 5 of the instruments for quality or for better, prices and all those things. So there is a detailed one in which all the 32 instruments are listed out and what is the state of that in the country. And then we have suggested what needs to be done. And beyond this, we are telling, move beyond coverage, move towards a health system. Because by health system, by definition, means all actors, all systems working towards the health of the people, not just healthcare. So that is why universal health system holds more promise than the financial insurance coverage based universal health coverage phrase. So UHS can offer comprehensive services. UHS provides for greater solidarity. The package approach of UHC results in fragmentation of care. There is no continuum of care with no backward and forward linkages. That can be overcome through a universal health system, and universal health system holds the promise of primary health care through social determinants of health. In effect, because health is socially, politically mediated, because of the inequalities, because health falls through the cracks of inequalities, UHS can provide for universalization of social protection. Thank you.
Thank you, Prasanna, for such an amazing presentation. I learned a lot today, and the critique of universal health coverage as this concept is it's really interesting, because this is what I learned when I was studying UHC in university, right? So it's a very interesting insight about how politics of health and neoliberal policies have dramatically changed how this concept for health for all was conceptualized. So let's move to our third speaker, Dr. Ritu Priya. Over to you.
Hi, so thanks, Leah. And thanks to both the two previous speakers for having laid out the issues so well. Thinking of the future is always very dangerous, because one doesn't know what one is talking about till it actually happens, right? So I thought I'd try and first just map out what is it that we are thinking about, and then try and see the possible scenarios, right? What the universal health coverage as the topic that we're looking at is to be considered, one, in terms of the costs of health for all and financing of that, the content of what we mean by this, and this has been well laid out both by Prasanna and Amar before, and the design of the system as we see it, right? And the three have to be correlated. The coverage issue in terms of, when we've been talking about right to healthcare and so on, one large part of it across the world has been a demand for more financing, and that there has been an inadequate financing. So that looks at one kind of arrangement, which we have had since the 20th century in terms of the welfare state model. starting in the 19th, but much more in our parts of the world in the 20th century. And that welfare state model was built on public financing and public provisioning. What it was not able to do was a actual provisioning of universality. While in theory it was a universal public financing and public provisioning. And this can be laid either at the door of lack of political will to do it, or it's something I would contend as the content and the design of the system, which did not allow it to be adequately universalized. Now, therefore, sort of the future would have to be looked at in the context of the past. And so I'll keep sort of switching back and forth between this. But so this welfare model was one that we had very clearly with public financing and provisioning. Today, as what we have is the neoliberal version of it, which says public financing, but private provisioning. And moving to that is where a lot of the opposition from groups like the MFC and the JSA and so on, People's Health Movement, has come from. Both of these do not really look at content and design of what is being provided, I'm afraid. When we take a rights approach, we're talking about what is considered the best healthcare across the world, which is what is in high income countries, is what should be universalized to all in the world. Now, I'm not sure that's the best thing going forward, because we've clearly seen that with those development models, ecological degradation, the iatrogenesis that Amar also referred to, are all parts that we are clear on. And third, which we often don't adequately talk about, is the unaffordability of that system, even for the high income countries today. The fact that when we talk about 2.5 to 3% of GDP going to health, I mean, in the Indian context, we do that. The WHO says 5% of GDP. For what? Is it for secondary and tertiary care? Is it for primary level care? Is it for social determinants of health? Do we imagine that 5%, even 5%, will give us all these together? So what are we demanding? What are we imagining as the future of universal health? Because what we have as estimates by the high-level expert group, by WHO, this 5% is for basic health services. We tend to ignore this dimension. And if 5% of GDP is what is expected for basic healthcare by WHO, in India, we talk of 2.5 to 3%, whether it's the national health policy or our rights advocacy that we do, that barely covers primary level care, when that is done through public systems in an adequately laid out provisioning. Therefore, if we take that into cognizance, can we see the 19th, 20th century health services as the desirable universal health that we see in the 21st century and the future? Because if we do, then we are clearly in for disappointment, because it cannot happen, right? Now, that can always be belied by giving examples of countries which have done it. But as a planet, it doesn't seem to be possible. And therefore, we need to look at the content and the design with much more care. Now, in the content, what the recent, the 2018 Astana conference did on UHC did say that PHC is essential for UHC. That only meant that it brought the primary level together with secondary and tertiary, right? Because the universal health coverage was insurance based and basically hospital care. So UHC was the initial version of it was about secondary and tertiary care alone, and how to provide the finances for that, so that that imagination of the early 2000s of catastrophic expenditure being only from indoor care is what the imagination came from. But we've moved from that. We have enough studies to show that it's primary outdoor care as well, which does this, and therefore secondary and tertiary and primary coming together. Now that is, to my mind, a movement because it's breaking away from the fragmentation of primary, secondary, and tertiary. And if you look at an actual practice of systems design, a lot of that fragmentation has actually got broken down by the private sector, because you have the corporates coming down to franchising the private sector, the primary level, and trying to build this because that's how the market is profitable for them. Therefore, what one could see if one follows the model of more of the same, the private sector and provisioning and the financing by the state being of primary, secondary, and tertiary care brought together in the same kind of institutional care. What it leaves out completely is the community level of care. And that is where the Alma Ata had drawn us. And the benefits of Alma Ata had come in terms of development of community level services in all countries across the globe, even though not adequate to the imagination of the Alma Ata. But yet that step had been taken. Now, if we want to see the Alma Ata model and imagination in the future, then how do we get to that? Because that's where our critique of the UHC coverage model with insurance really lies, right? So how do we even dare to dream of a future which could be in the spirit of Alma Ata? I think there are, if we look at the way Alma Ata did come, and it is a document that till today nobody is able to stash. Even the World Bank post-pandemic comes up with a document saying reimagining primary health care, walking the talk, right? So if World Bank has to come to that, and it actually acknowledges that the move from comprehensive primary health care to selective primary health care was a mistake. So the pandemic clearly did bring this level of rethink, even in the World Bank and its stated documentation. What we have other than that is, like I said, the unaffordability which the high income countries are facing, and of course the inequalities that we see across countries and within countries. Now, this is a major concern, and therefore the issue of UHC, the way we've seen it, but the Astana conference shows us that there is an opening for a larger imagination coming in. Now, if that is happening, that's certainly a window of opportunity. Both the recognition of inequalities, the unaffordability of care as it is, and the content of that care as it is today, including the iatrogenesis, and then the pandemic and what we experienced through that. So that provides some bit of opportunity. The sustainable development goals, not necessarily in the way the private sector and the green industry and so on is bringing it to us, but again, in its conceptualization of the three pillars of economic viability, social justice, and ecological integrity. If we take those as a basis for a future health system, then that gives us the possibility of openings for a different imagination. Why I'm saying that we could dare to think of something different today is because Alma Ata was certainly a complete break from the doctor hospital centered model that was available to us from Europe and North America in the 1970s. And the world did do that, even if for a short time in practice, but certainly put down a document for us, which keeps the imagination and the flame of that spirit alive. And we're all able to keep going back and draw from it. So do we see an opportunity of that kind, a window of that kind today? I'd like to propose and hope it may be seen as complete wishful thinking, and I'm ready to concede that it may be so. But I do think there are opportunities and the possibility of having that same window. It was again a 3 or 4 year window really that we had to have the Almar. But today, with the pandemic and the inequalities and the ecological crisis, climate crisis clearly hitting all countries in various ways, and the middle class being affected as much as the poor, or maybe not as much as the poor, certainly the poor suffer most, but certainly getting hit in various ways. And therefore, the possibility of political pressures getting built up on it. Now, in this, why I'm calling it wishful thinking is because somewhere even post-pandemic, we do not see a politicization of health and healthcare the way one would imagine that the pandemic would have brought it on. Yeah. And yet it's happening in small ways. And countries are responding, governments are responding to some extent in these various, it's been documented in various states in India, as well as in different countries in terms of nationalization of health services by Spain and so on. And there'll be a whole host of things. I won't get into that. There's hardly any time that I have remaining. But therefore, I think what we need to think about is what are the possible, how can we widen this possibility of window of going back to the spirit of Alma Ata, but learning from the hindsight of 40, 50 years, and now restating it for ourselves and for a larger imagination, for which one would have to have advocacy, mobilizational skills, and so on. The knowledge space is where most of us work in. That's where we intervene, and through which we would have to intervene to generate knowledge of that kind, which would bring attention to the mirage that the 19th-20th century health services have created for us, and the medical industrial complex continues to perpetuate. And we're tending to buy that with this universal health coverage discourse and insurance pitching into that as part of the medical industrial complex. So countering that, showing it up as a mirage, and creating a counter imagination of what health means, which is the wider imagination of health as coming from the determinants, from what the conditions of life and so on. The SDH Commission document says that quite well. And thereby can health be the center point of socioeconomic planned development of countries rather than economic growth being the agenda? Can that be the point of shift that we should be moving towards and try to make? Then health for all starts becoming a larger imagination. But it would mean that the data we generate would have to come from a much more holistic epistemological base, allowing people to be involved, the community level that we're talking about, being missing from this institutional imagination of universal health coverage. It has to add on that, and that's the only time when people actually become relevant, acquire agency, and thereby that agency, which if we look at any anthropological studies of healthcare, of health-seeking behavior, show us that the bottom line of healthcare is what people decide to do in their own lives. Even if you take a horse to water, it has to drink. And that's what everybody, you can provide health care, but eventually it is how people perceive it and experience it and how they understand it that actually makes the final difference. Of course, all the systemic constraints that are there, I'm not pushing those aside, but therefore how you bring the community and people and the household central to the design of healthcare and of health knowledge generation has to, according to me, to be a part of our future agenda of moving to health for all and not to universal health coverage as institutional care. These possibilities exist if we look at historical cycles of movement, civilizationally, of human civilization and society, and how these windows of opportunity appear at certain moments in history. It is for public action of people coming together and doing collective action on it, which can push the knowledge industry also in a certain direction. And all of us being part of that knowledge industry, and then part of advocacy and mobilization and political action in to different degrees, would be where we'd also have to take that responsibility of looking at the complexity of the situation and of the problem, and not just pinning it as governments and their funding being inadequate and so on. That's just not adequate. And a diagnosis of the problem. The problem is much deeper, and unless we do a complex diagnosis, we won't have a future of health for all. Because the larger capitalist system and the medical industrial complex is otherwise so powerful. Power, as political scientists have taught us, and I think the national movement of India shows in some way, power is what is legitimized by people. If we accept power of the ruler, it is there. If people stop recognizing the legitimacy of that power goes away. It loses its power. Can we start going to those kind of imaginations again and really empower ourselves with that? That's when health for all can become a reality. Otherwise, the dominant system certainly has its way and has its power.
Thank you so much, Dr. Ritu Priya. So this was a very interesting talk, and the fact that WHO actually requires 5% for basic services, and that's really bizarre, because in Pakistan as well, our GDP, our health expenditure is not more than 2.5%, and a lot of it goes again, as I think the Indian problem Pakistan faces the same problem. It's mostly on tertiary healthcare services, and I think I hate using this word, but as consumers of healthcare services, people also want big tertiary care hospitals because they're more attractive. So even in the Sehat Sahulat program, which was started as part of the UHC within Pakistan, you have these basic packages of services, which Prasanna has, of course, critiqued, that you have these basic package of services which are really just centered on within hospitals. They do not cover outpatients, medicines at all. And there are stories that are being reported from within Pakistan that a lot of people are turned away from private healthcare, which are actually part of the Sehat Sahulat scheme. So a lot of poor people who lack any kind of advocacy, etc., are unable to get their health needs met. So this has been an excellent discussion, and we have a couple of questions, and we can ask all three of the panelists to perhaps field those questions, whoever wants to. So we have one questions that, and I think we've partially answered it, but I think we could do a deeper analysis of it, is that why are the governments failing to recognize social factors as determinants of health? And there's spending on pharmacological interventions, or they're talking about technology, they're focusing more in technology. So anyone who would like to take the question?
Well, you want me to take up?
Yes, Doctor. Yes.
Because it's a general and I think historical question. So I thought that I don't think there is any government or anybody in this world who does not recognize the social factors. We all know that if you don't eat, if there is no nutrition, if there is a contaminated water supply, your health is going to go down. I think everybody has the general knowledge of that kind. But the issue is not there. The issue is political. It is political simply because you cannot understand a government and the larger state power without its context, that what it represents and who controls it, and what is its ideology. Most of the states are, there with an ideology to manage the market economy. That is their major job. And as I was explaining to you, the market in itself does not need healthy people unless they are productive for the kind of economy they are running. And those who are unemployed, not employable, in that economy, or whose skill and quality is not good enough, they just can be marginalized and forgotten. Right? They don't care about it because ultimately they care is the expansion of their profit and the economy. So this is where the government is. The government, if it represents the people to the extent that it has to come for what, that is where the people come in the picture. And they say that, well, make health a political issue in the election, which has not been there, I think, in most of the developing countries. The caste will be issue, the religion will be issue. There'll be all kind of other things will be issue, but not the healthcare. Even education has a good political profile, not the healthcare. And as a consequence, this doesn't come up, right? The other thing is that unless people make a demand, you just look at Europe. I mean, there is a political lesson there that the reforms that took place there for universal access, even for the medical care, were all determined by a lot of struggles of the people. It was in that context. And the struggle was for complete social security. I mean, you won't find any of the European country or the Canada who just did healthcare reform, but did not do reform in employment, did not do reform in education. It was part of the larger social security, that as a right of all the people. I think that is where the working class movement, the movements of the women and other oppressed strata in those countries made a big impact there. And I think we need to keep that in mind if you want to really achieve this part. So it's not that government does not recognize. You have to make them to recognize. You have to push them through your struggle by raising the political issue. Then it will come about. Whether it is a food for all, whether it is a safe water for all, or it is a primary care, or it is a a comprehensive healthcare coverage, whatever you are talking about. I mean, you can have a discussion. We can have a discussion among us that which is the better strategy. The insurance is better strategy, or government doing provision and all. But none of that will work unless we have a strong movement for the universal access to the determinants of the health as well as the biomedical healthcare services. And I don't like people who say that this there is a big contradiction between determinants and the clinical healthcare or medical healthcare. Both of them are needed. You cannot have a a very one type exclusive thing and say that, well, we will work only for the socio-economic. That means, Virchow was right at that time, but at that time, health services were not developed. So he said that doctors should be engaged in the social agitation. Yes, doctors should be engaged, but that does not mean that doctors should not be engaged in reforming its own healthcare services or medical care services. Both have to be done together. And also, they should draw other people, non-doctors, into the reforming of the healthcare system. I think that is what is required. So yes, government can be changed. Government's attitude can be changed, provided we have power, a people's power to do that, which we don't have at the moment, which is a big challenge.
Yeah, but that's also the model, Amar, of Kerala and Tamil Nadu to some extent, of how people's power on the larger social security, social issues, and equality, struggle for equality, helped in better health systems. So health system per se cannot improve health in some sense. It has to be the other social systems that Amar highlighted. Yeah, three axes there: capitalistic axis, power of biomedicine, combining together that makes it very powerful for the government to not look at the other social determinants. Yeah, I think that should be good enough to answer that.
Silly, I just want to point out that two things. One, that the present across the world rightist governments, as it's tending to become, are using the welfare system as populism. So for example, in India, when we have the Ujjwala scheme where clean fuel is being given to women free as gas cylinders, and Swachhata Abhiyan where toilets are being given free, are being touted in the name of public health and improving health as well. And it is reaching a certain percentage of people, thereby also is addressing social determinants, but not in terms of being tied up as a health system or health care, but as part of the welfare. So today, welfare, as it was seen in the 20th century, has actually got taken over by the rightist political powers, rather because it's still the same, more of the same. They can do it in that same model, and therefore are just going, advocating for that more. Only further goes into their hands. Nutrition during pandemic, 80% of people in India being given free rations, even if inadequate, are all part of that kind of, and you see it from the US down to India. So it's not just India which has that kind of a thing. Therefore, what is it that we need to see SDH as? It's not just these about water and nutrition and this, it's about people's agency. It's about their empowerment and their decision-making power. That is what the right is taking away. How do we get that back? How do we get imaginations of women and their health, of Dalits and their health, of different communities and their health as they see it, back into the understanding of healthcare? I think that's a big challenge for us.
Ritu, one caveat here. I just wanted to put it simply because when you say the right wing using the concessions of this kind as a vote bank, creating vote bank to continue in the power, which is there, but at the same time, they themselves say that these are revdies, it is like what Modi talked about, But the important issue is overall, if you look at the right wing in the world, they have actually played a big role in dismantling the welfare state system. And we must keep that in mind. And in India, while giving this kind of incentives to people in a very haphazard manner, they are also dismantling the public health system of whatever kind, howsoever weak it was, which was created from 1952 to 1980s or 90s, whatever that primary health care centers and the government hospitals and all which were created, they all are being undermined by the right wing. So the point is that in the general population has ideologically embraced market, and I think where NGOs played a very big role in telling people that unless you pay for your services, you won't get good services. And this was in 1980s. It was a post Alma Ata, where in most of the NGO activism that happened, that people have to pay from their pocket, and that's how the user charges came about. And ultimately, even World Bank had to go back on the user charges, apart from the other people. So it is very, very important to understand that right wing is undermining the welfare. I mean, welfare as a single term and welfare statism or welfare system is a totally different political connotation. And they are actually undermining it, actually trying to dispose of it and trying to replace it with the private. And look at what is happening in UK. Most of the health workers are on the street fighting against conservative government for the preservation of the existing national health system. So that we must keep it in mind. That yes, they are using as a populist, but at the same time, they are also undermining the larger system of whatever kind that was existing there.
Sorry, one additional point is the informalization that is proposed through the neoliberal mechanism. The informalization kills the social security of the people. And even though some SOPs are given, it is a It is made as a dependence mechanism rather than as an empowering mechanism. So the so-called welfare is not welfare, as Amar pointed out. It is more a soft to keep populations at a particular simmering level rather than giving them as a right, as a formalization of labor. The neoliberal tendency of making more and more informalization, I think that is what we call about when we talk about universalization of social protection in health. I think that is where we have to move to. Sorry, yeah. Next question, if we have, or are we running out of
Yes,
time?
so just we have one more question and then we can perhaps wrap up after this. If one of the participants has posed the question that if share of public hospitals from insurance overtakes share of private, do the panelists feel that that would be an acceptable model of PFHI? And I think the question is posed to Dr. Prasanna.
No, actually, that's a what you call that is disingenuousness. No, it is a disingenuity that you want to operate a system through insurance mechanism. It is still only healthcare, whereas what the Tamil Nadu government and Kerala have built upon is a system that was based on public health system, and now they are bringing in the market mechanisms. So in some ways it might work there, but you are still not catching the point that we have to move towards universalization of social protection. I think that is the bottom line. Just giving some care, some cure, some insurance is not going to solve the problem, because invariably the poor get left out. The social stratification theory says how the poor get left out because of the lack of power, status, and energy. So the way forward is not some hodgepodge insurance here, some coverage there, breadth, width, height. We will get caught up in this rather than looking at universalism as a universalization of social protection. Sorry if I answered.
And I think just to add on to it, Dr. Ritu also talked a bit about that, when she spoke about the multi-sectoral elements of healthcare and the fact that all of this needs to come together to kind of to kind of improve upon universal health. Well, health for all. I have to reconstruct my thinking as well. So thank you so much for a wonderful.
Can I just add a small point to
Yes.
what you were saying? I think what happening in Kerala and Tamil Nadu, one may feel nice that public sector is getting more insurance, but believe me, what is being done is that instead of providing money for running the public sector, government is throwing the public sector into the market to compete with the private sector. And that is the first step towards privatizing the government services, because you are making them to compete in the market. And however progressive regimes may be in Kerala, the communists and DMK in Tamil Nadu, they are actually getting into the trap, which ultimately undermine the public health system. So this is a very big structural change that is being carried out. And I think we need to keep it in mind that they should not be made to compete. They should be made independent, financing of them, so that all the investment that is required to take care of the patients they are getting for that. And that's very important. I think there's another point is that, till the health is treated as a kind of a need which is to be provided, and people don't understand it as their right. The problem is that there won't be big resistance from the below to improve things. And that's where I think for you and me, those who call themselves, health activists, the work is cut out for us. That unless people take that as a political issue to fight for, we all can talk about that, have a lot of seminars and all, and we can also sit in the policy making bodies and keep making all the recommendations, but things won't change, because if people are sold to market, it is very difficult to make changes here. So yes, I think we have to do a lot of hard work in the developing country to achieve.
Yeah, one last point, just on the insurance part of it. And sorry, given that this is a bioethics group, so-called, I think if insurance covers irrational hysterectomy, even though it is supposedly supporting the public system, that doesn't help. So, and insurance as a mechanism itself is a little problematic in some sense, but at the same time, coverage for coverage sake might not be the way of moving towards social justice. So, sorry, thank you.
No,
So
absolutely.
I just want to act as devil's advocate and leave
Okay.
people with one thought. Okay, and I know we are running out of time completely. We are over short time, but just one line. Can we all sit back and imagine one centralized public system, even within our states of India? I mean, because since our audience is largely Indian, and think of one large, complete health services, well administered, and just as bureaucratic as it could be. In today's world, is that our imagination of the future?
And I think that's a very nice thought to kind of end this session with. And we're really glad to, on behalf of the South Asian bioethics community, I would really like to thank all three of our panelists. I'd like to thank all of the participants for joining in. Special thanks to Roshni and Priya, who organized this entire event. Thank you, everyone. And we will be there next month. And sign up on our Facebook page, like us on Twitter, register, be part of the community, and let's shape bioethics discourse in South Asia.
Thank you.
Okay. Thank you so much.
It was a pleasure.
Thank you. Bye-bye.
Thank
Bye.
you.
Thanks for.
Bye.
Bye.